Hello, my name is Villalona, and my patient care presentation today will be focusing on sepsis. In nursing, it is understood that sepsis is a life-threatening complication that can arise from infection. The source of the infection can be from a diabetic foot ulcer to a scrape on your knee. If the source is not disinfected and dressed, it could allow bacteria to enter the body, causing a systemic infection. If the sepsis is not caught quickly, it could lead to organ failure or even death. My patient was a 53-year-old male, Caucasian, and had no known allergies. He had been admitted in September 2021 due to feeling feverish, having shortness of breath, and feeling fatigued. At admission, his oral temperature was 101.9 degrees Fahrenheit. His heart rate was 119 beats per minute. His respiratory rate was 23 respirations per minute, and his blood pressure was 110/67. He had stated that his blood pressure was typically around 140/80. An initial assessment was done on him, and a stage 3 pressure ulcer was found at his coccyx, which was about 4.1 centimeters high, 9.3 centimeters long, and 1.1 centimeters deep. He noted that he had been having some episodes of incontinence, so he had started to use briefs for 2 weeks before his admission. His upper and lower extremities were cold and clammy to the touch, and he rated his pain being 8 out of 10. Blood was drawn, and his white blood cell count was found to be 11.6, and his serum lactate was 2.4. A blood culture was done, which came back positive, and the gram stain came back positive for E. coli. After looking at his values and assessment data, the physician had diagnosed the patient with sepsis. At the time of admission, his medical history consisted of having a stage 3 pressure ulcer for an unknown amount of time, being diagnosed with morbid obesity with a BMI over 40, type 2 diabetes, and hypertension. Compared to the national average, my patient had fallen within the standard demographics of those patients that had developed sepsis. In 2021, the Centers for Disease Control and Prevention found that at least 1.7 million adults in the United States developed sepsis. Out of the 1.7 million cases, 87% of those episodes of sepsis start outside of the hospital. Powley et al. Did a study to determine epidemiology of sepsis in the United States in 2018. Out of roughly 2,500,000 patients that were diagnosed with sepsis during their admission, the average age of patients that were diagnosed with sepsis was 65 years old, plus or minus 18 years. 49.2% of those patients with sepsis were male, and 71.8% were Caucasian. Medical events or comorbidities found in these patients included hypertension and diabetes. 50.9% of patients that had sepsis were hypertensive and 27% were diabetic. Other comorbidities included a history of cancer and a weakened immune system. Finally, 79.7% of the patients were directly admitted from their home. So, how do you treat a patient that is septic? If there's a significant suspicion of sepsis or septic shock, treatment must begin immediately to prevent the infection from getting worse and causing more complications. Regarding pharmacology, there is a 1-hour sepsis bundle that was done on the patient at admission and has been found to be the most effective. This medication management was made by Levi, Evans, and Rhodes in 2018 with the intent to treat suspected sepsis at a faster rate. First, the patient will have labs drawn, where their serum lactate will be drawn to determine if there is tissue hypoxia. Their blood culture will also be obtained to determine if there is a presence of bacteria. Next, a broad-spectrum antibiotic is given, which will be used to prevent the infection from getting worse and cover a wide range of bacteria until the specific gram of bacteria is identified. My patient was given amoxicillin to cover him before the gram stain was able to determine the type of bacteria. Then, the patient must be given 30 milliliters over kilogram of crystalloid quickly. For the crystalloid used, my patient was given 0.9% normal saline. The normal saline helps with the hypotension and regulate the lactate level. Finally, a vasopressor is given to work in tandem with the normal saline to increase the patient's blood pressure. My patient was given Lovafid or norepinephrine as their vasopressor. After this bundle is done, the patient was observed and monitored for any changes in their vital signs and level of consciousness. Serum lactate levels were repeated every 2 hours to determine how effective the hour 1 sepsis bundle was based on lab values, as well as assess how well the prescribed medication is working. My patient's gram stain came back with E. coli, so the patient was given Levaquin to treat with the specific infection. Since the pressure ulcer was determined to be the source of the infection, the sore also needed to be cleaned and disinfected. The pressure ulcer was treated with silver sulfazine, which was a topical antibiotic commonly used to stop bacteria from growing in a wound. A study done by Norman et al. In 2016 found that a 3-week study, silver sulfazide was more successful in stopping bacterial growth compared to the other topical treatments, such as povidone iodine. Regarding medical treatments available for sepsis, there is little to no medical treatments available for sepsis, since it is a systemic bacterial infection that can only be treated with antibiotics. Martinez et al. Found that numerous studies failed to find other types of interventions to treat sepsis other than antibiotics. The only kind of medical treatment available is the prevention of sepsis. Regarding my patient's case, although his sepsis began at home, hospital-acquired sepsis can also be prevented by following guidelines such as practicing frequent hand hygiene, providing proper skin care to avoid injury or sores, and keeping sterile technique with appropriate intervention. Due to his diagnosis, the most important assessment data I focused on were his vital signs that were taken every 4 hours when I worked with him. His temperature and blood pressure would be checked to determine if there was any trend that would imply that his course of antibiotics wasn't working. Regarding his lab values, the patient's white blood count, as well as their serum lactate levels, were checked frequently to determine if the infection was going down and to measure tissue perfusion. Regarding my knowledge of the disease process and how the patient presented, the key signs and symptoms were presented when he was first admitted. When I had worked with him, he had already been treated for 2 days, so his lab values and vital signs were demonstrating that his sepsis was under control. My main goal during my shift for the patient was to prevent further infections from happening. The nursing interventions I implemented was to wear appropriate isolation while in the room and practice hand hygiene before and after I leave the room. Since the patient was still very weak to bathe themselves, I would help the patient get a bed bath and clean areas of his body that could allow bacteria to grow, such as perinatal areas. I would also make sure he was completely dry to avoid having other pressure wounds from happening during his admission. Prevention is the best way to avoid sepsis, so nurses must educate their patients on how sepsis can occur and how to prevent infection from happening. Dantes and Epstein's 2019 found that educating the public on the early signs and symptoms of sepsis, as well as how to prevent it from happening, can drastically decrease the number of sepsis admissions. Finally, due to the complexity of sepsis and how it affects the body, it is critical that these multidisciplinary collaboration to treat the patient quickly and effectively. Lorch notes that collaborations must be done with the pharmacy to make sure their antibiotics are treating the sepsis. The nurse must also work closely with the physician and inform them of any changes that are presented, so orders and treatment plans can be done as soon as possible. By the end of my shift, I felt that I had achieved my initial goal of preventing further infection to the patient. When I got back to the floor the following week, I found out that my patient had been discharged 2 days after I'd worked with him, meaning he was admitted in the hospital for 4 days total. So if you believe there is a suspicion for sepsis, make sure the patient demonstrates some of these signs and symptoms. Do they have a fever, low blood pressure, feel cold and clammy, loss of consciousness, feel short of breath, experiencing tachycardia, or having a high respiratory rate? If the patient is not demonstrating any of these signs, it is possible that the patient may not be septic or has not progressed efficiently yet. So make sure to monitor for changes or assess for other disease processes. If the patient has demonstrated signs and symptoms similar to sepsis, then make sure to do the 1-hour bundle and add the gram-specific antibiotic when available. Remember, first, for the 1-hour bundle, measure the serum lactate, and it should be checked every 2 hours after the 1 hour is over. Obtain blood cultures, administer a broad specific antibiotic, administer your crystalloid, it could be lactated ringers or normal saline, and administer a vasopressor. Doing this septic bundle in practice was implemented to decrease the amount of time needed to control the bacterial infection. If the first implemented in 2018, it has been found to improve cases of sepsis, which is why it is now considered a vital component needed for treatment and prevention of further complications. If the patient's serum lactate is still elevated, maybe you should recheck your plan. It is possible that the patient may not actually be septic, or you just need further diagnostic tests to have it confirmed. If the patient's elevated serum levels have stabilized and have decreased, continue the plan of care and monitor. Also, make sure to prevent any kind of infection. Remember, treatment for sepsis can be really difficult since it depends on the infection and how much it is infecting the body. Make sure to practice preventative measures. Capper, Wong, and Martin stated that simple interventions such as practicing frequent hand hygiene and wearing isolation can drastically decrease the chances of causing infection. Now, some key points to remember. Sepsis is preventable. It can be prevented by avoiding infection and practicing good hygiene. Time is very important for any patient that could be septic. You can't second guess it. If the patient has signs or symptoms, assume it is sepsis and treat accordingly. Always monitor your patient when they are admitted for sepsis and after they receive treatment. Check for any changes in their blood work or in their head-to-toe assessment, since this could imply that the treatment is no longer working or that the patient got reinfected. Prevent opportunities for sepsis to even happen. Avoid Foley catheters if possible to prevent infection. Make sure you turn the patient every 2 hours to avoid developing pressure ulcers. Clean and treat the source of the infection to prevent bacteria from growing. In the following 2 slides, I have shown the references that I have used for this project. And that's all, folks. Thank you very much for listening to my presentation, and I hope you have a wonderful day and feel more educated about sepsis.